Hello, everybody. It's about time we have to start our learning. Well, uh, as I presume, most of you are logged in or you're planning to get benefit from the recording. But I have one simple advice. If you are part of this discussion, because it's more a discussion and a review rather than I don't believe in re-lecturing again and again. My sole idea is all about learning and learning how it promotes the best when we are engaged. So if you are engaged in one-to-one kind of discussion, then you have the max kind of learning. So maybe so many of you are thinking, oh, fine, when we are done with the things, we could sit down and watch. But the problem is, if you don't get engaged today, the bottom line comes when you leave it for the last, which usually the case, then you don't have a lot of time, and then you have a lot of questions, and then you'll be struggling and trying and asking here and there, and you may get answers, you may not get answers. So the best practice is to go over. Now, when I was looking at it, how to execute this activity, I used to do it in the past a lot of times, especially during COVID time. We used to have these kind of sessions quite often. And then today I decided to start from the scratch and I have highlighted some key area. I'm open with your chat. So you need something, you can write in the chat box or the Google documents which has been provided to you. I assume the BLCs are around so they can help me with their Google Doc. And from there, I'll be able to answer some question because this Zoom chat thing, you type in something and then it will be overwhelmed. A lot of things are there. Then scrolling up and down will be a little bit time consuming. So I'll be using all kind of activities. And my simple advice when I'll be reviewing things, I believe in finishing on the spot rather than zipping up everything and then coming back and forth. Are we clear so far? Guys, you can write in the chat box. I have no problem.
All is clear, doctor.
Okay, so let's start our learning. My first topic today, I have this slide is demonstrating primarily the bones which we have learned or will be learning during our upcoming days. The first bone which we have talked about was this guy, the clavicle. We talk about it, it's a modified long bone, it's present horizontally, we talk everything. But what is more clinically relevant in this bone is that the common site of fracture. And this is where I'm drawing. That's the most common site of fracture where 2/3 and 1/3 meet with each other. That's the commonest site for fracture. What is the next thing which you must know? Especially its undersurface, where you can see, if you can pay attention, this is the conii tubercle, and there is this line to whom we call it the trapezoid line. Because here we have attachment of my coracoclavicular ligament. And disruption of this ligament plays a significant role when we'll be talking about shoulder separation. Then this end, which goes to my sternum, it makes a very important joint, and that is my manubro. What is the name? What is the name? Sternoclavicular joint. And we talk about it, it's a saddle type of joint. And then the other joint, which is between my acromion process and the acromial end of the clavicle, that's a plain synovial joint. Do you have any question regarding the learning of the clavicle? If there is any, please write in the chat. Is there any question? So no one is writing, it's fine. Then what else to be known with this clavicle, especially when this bone fractures? So what we ask commonly, when this fracture, why this end goes up? Who are the factors? Why arm goes by the side of the body? And why elbow is being sunken downwards? We all know we have attachment of a muscle of the neck, which we call it sternocleidomastoid. That is someone who pulled it up. And then we have talked about other factors. Are we good so far? Anything which bothers you here? Okay, so nobody is writing anything. Now coming to the scapula. Scapula we learn, it has a ventral and dorsal surface. Primarily, it has muscle attachments. Another thing which is related to my scapula that will be coming up in our few slides, there will be talking about the anastomosis around the scapula. So let's talk when it comes there. Now let's move to this bone, which is called humerus. So in this humerus bone, we have learned a lot of features, but what is more relevant for your learning and for your exam process? The main features are surgical neck, the most common site of fracture, and this fracture leads to loss of some functions. And who are the structures who are related to this site that we have already talked about? We have axillary nerve and we have posterior circumflex humeral artery. So these are the 2 points, 2 structures. One is the nerve and one is the artery. Are we good so far? Going further, then we move to the shaft of the humerus. So when we'll talk about the shaft of the humerus, what do we have in the shaft of the humerus? We have again 2 structures. So where it is that? First of all, this is the place where we call it as a shaft of the humerus. So mid shaft. So mid shaft fracture. In this location, we have 2 structures. What are these 2 structures? These are my radial nerve, and the second structure is my profunda brachii artery. So they are susceptible to be injured and loss of functions associated with their losses. Then the last relevant thing is about this guy. This area, if you have fracture of the distal humerus, supracondylar fracture, and the structures susceptible to be injured, median nerve, brachial artery. Then another important landmark, this one, medial epicondyle. You're looking from front and back. So this medial epicondyle, just behind it, we have the ulnar nerve. So ulnar nerve is gone, so all the functions of the ulnar nerve will be lost. Are we good so far? So now coming to another important topic, which is very relevant with our learning and assessment. So this medial epicondyle, if we have inflammation at this area, which is medial epicondylitis, or we call it in a common language, golfer elbow. And the lateral epicondyle is the tennis elbow. So these are the 2 terms, and we all know to this common flexor origin or the medial epicondyle, we have the proximal attachment of most of my superficial muscle which are present in the anterior or the flexor compartment of the forearm. The other muscles also take attachment at this location, but primarily the superficial ones. So they will be affected most likely. And then if you go for the tennis elbow, there will be talking about extensors. Are we good so far? So now let's move to radius and ulna. Now my radius and ulna bone. What we need to know, this trochlear notch, it makes an articulation with the trochlea of the lower end of the humerus, and this radius, head of the radius, go and articulate with the capitulum, which is also present at the lower end of my humerus. Then you're looking at another relevant important landmark. This guy is my radial tuberosity, and that serves for the attachment of my biceps brachii muscle. Its tendinous part come and get attached in this location. Are we good? So pronation and supination, especially supination, is happening because of that, and biceps is a major supinator muscle. And then we have 2 joints. One is upper radius and ulna, one is lower radius and ulna, and there is another joint in between but that is not a synovial type. That is a syndesmosis, where a thick fibrous intraosseous membrane, which has been attached to the intraosseous borders of these two bones, and they are anchoring these two bones together. So we have three types of joints. Two are synovial, and one is the fibrous variant. And which variant? Syndesmosis. Okay, going further. So what are the movements occurring at my proximal and distal radial nerve joints? Primarily, they assist in the act of supination and pronation. Are you fine with that? There is one more important structure. The lower end of the radius, this place, it's highly susceptible, especially when someone falls on his outstretched hand. What we call it, this outstretched hand, fall on outstretched hand, foosh. So when an adult falls on an outstretched hand, we have a fracture which occurs at the distal radius. And this is famous as Colles fracture. And there are a lot of questions which are associated with this Colles fracture. We all know an important muscle is attached distally near to my distal radius, and that muscle is my brachioradialis. This brachioradialis muscle is very special. It is attached to the lower humerus, then it comes down all the way to get attached to the distal radius. This muscle is innervated by branches from the radial nerve. It stays in the extensor compartment. But when I have mid-prone position, at that time, in mid-prone position, it is one of the flexors of my elbow joint. And this same muscle, when we have fracture of this distal end of the radius, this fragment of my radius, it stays. The whole thing sinks down. That's why we have dinner fork kind of deformity. And who maintains this distal radius in its position is nothing but this brachioradialis muscle. Guys, this is a high yield concept, and you are expected to be connected with this learning. Are we good so far? So now let's get over. So no questions so far. Fine. So now we'll be moving on to the hand. And I'll be going into the bones of the hand. We learned these are my carpal bones. And carpal bones are 8 bones. They are arranged in 2 rows. And they have joints in between. Then we have these bones. These are my metacarpals. And then if I take my 4 digits, guys, don't make a mistake. This is digit number 1, 2, 3, 4, and 5. So look at 2 has 3. 1, 2, 3 phalanges. So we call them P1, P2, P3. My middle digit has the similar 3. My ring finger has a similar arrangement. My digit minima or pinky has the same 3 phalanges. But if I come to my thumb, my pollicis, it has only a proximal and a distal phalanx. So this is only having 2 of these. Are we good so far? Okay, then let's move further. So is there any question which is bothering you when you're learning these bones of the upper limb? Anything which is bothering you? I presume people prefer to be muted or vice versa. So there are no questions. Are you fine? Okay. So we are done with the bones of my upper limb. Now coming to this radiological image. So this X-ray, you will be given these kind of X-rays in the exam, and you'll be expected to answer, you'll be expected to identify the different features within these X-rays. If you look at this X-ray, to me, this X-ray looks like a normal radiological image. Remember, we learn one concept. When we are looking into an X-ray, when we are interpreting some human through a radiological image, we should always ask for an anterior-posterior, AP, and a lateral image. If we don't look at two views, we may not be able to identify so many features. Are we good so far? So guys, before I go further, let me look at your questions. Arterial supply, I'll be talking about that. You have trouble with the ligaments. I'll come over that when I'll be talking about joints of the elbow and shoulder. I'll go over with those ligaments. No problem. I have seen your questions. When I'll go to the joints, there will be focused more on those things. So now I was talking about when we'll be looking at x-rays, within the x-rays, you should have both views, anterior, posterior, and lateral view. So let's try to identify the different bony landmarks in this given x-ray. So if you pay attention, this bone which goes horizontally, that is nothing but my clavicle. This is my head of the humerus. That's my tip of the coracoid process. And there you can see this shadow that is reflective of my scapulae. And these are my ribs. Are we good? So these are my different ribs. They are running in their position. Now, what we are expected to look into this image, why I'm bringing it here. So let me erase all of these things first. So then it'll be more useful for our learning. So now if you pay attention, if you look at this head of the humerus, and if you look at the glenoid fossa, can you see this circle is engaged with another circle? So it means we are looking at a normal study. So this is a normal radiograph, and it is an anterior posterior view. And what are we looking at? Specifically, the shoulder joint or glenohumeral joint. Are we good so far? So this is a normal study. But guys, if this head of my humerus will come down somewhere here like this, then it will be first when we have a dislocation occurring at this joint, it has to go inferior. Then most of the time it goes anterior, and some of the time it goes posterior because of the pull of the muscles. Are you fine with this concept? Okay, let's go further. Now, some clinically relevant points. Fracture of the clavicle, I think we have talked about it. Fracture of the humerus, we talk about it. I mentioned there are three major nerves. And then we have talked about the surgical neck fracture, mid-shaft fracture, and the fracture of the lower end, and what are the consequences. We have talked about it. Going next, we have talked about Colles fracture, and I have mentioned about it. What is Colles fracture? It's a fracture of my distal radius, and there's a very classical appearance. And what I said, dinner fork deformity. That's a classic. If you look at the forearm of this patient, you will see this classic pattern. And this is because of there is quite an interplay of my brachioradialis muscle. That's why the distal broken fragment does not descend down, rather than the whole shaft goes down. And that is important clinically. And then fracture scaphoid. I didn't talk about it. When we fall on an outstretched hand, what happens? There is one of the carpal bone, which is boat shape, something like this. So this is called scaphoid. And when you fall an outstretched hand, and if I can draw for you, that's my lower radius. And just below to that, I have this scaphoid bone. So many times when we have a Fuchs type of pattern of fall, so this scaphoid may also fracture. So why we are talking a lot about this fracture? But there are other bones who can be fractured. This bone, very pertinent about it. You all know the bone has their vascular supply. So this scaphoid bone, if it's fractured, and when we'll be learning in detail, you have not learned it yet, so it has its nutrient artery. Now, there is one part of this bone which don't have arteries coming from this direction, or this direction. So the blood can travel from this direction only and can reach here. Now, unfortunately, if we have fracture, as a consequence of that fracture, what will happen? Let's say fracture is there. So this part of the bone will be separated from the remaining part of the bone. So there will be no nutrition, no blood supply. So this part of my scaphoid bone will become necrose. Necrosis means there is hypoxia. There is no oxygen coming. There is no red blood. The arterial blood is coming here. So this part will die off, necrosis, and ultimately it's a disaster. And we have to remove it surgically. That's why the scaphoid fracture, and what is most common about scaphoid fracture is primarily this avascular necrosis. And this avascular necrosis, primarily the arteries, and specifically a pertinent part of this bone, if it's fractured and we are not getting enough arterial supply, we might have this kind of consequences. And you can see here, it's mentioned here, it undergoes avascular necrosis. And then no matter what, we have to remove it surgically. And if we delays, it's a big trouble. Why has been emphasized? Because this bone, when it is fractured, unlike other bones, it's not very clear cut. So if you are suspecting this, and usually when you do an X-ray on this person, you may not find any finding. And but there is a hallmark. There is a persistent pain which is always there. So then we need to look into, because I mentioned to you, normally we do anterior posterior views and a lateral views. But in this situation, we have to look the wrist joint through different other angles so that we can reach to the conclusion. And we need more high yield diagnostic tools to reach to this part, because if we don't pick it early, and what is the sign? Patient will have a persistent pain at the distal part of his hand, at the wrist joint, and then that create the suspicion. And on this suspicion, we have to intervene. Otherwise, if it will undergo into an avascular necrosis, then it's a big problematic thing. Are we clear for that? Guys, write me in chat if you want me to talk more about this scaphoid fracture. I'll be doing on Sunday detail about this scaphoid and its other things. I'll be visiting during my session, don't worry, with more visuals. So nobody is writing in the chat, so I'm going further. Another very important landmark, Walkman's ischemic contracture. Guys, it's an high yield concept. And you can see, you can focus in this, if we zoom in this image, you can see how the hand of the person look like. And this is classical. This Walkman's ischemic contracture, we have a lot of involvement. Ischemia is vascular injury. So when someone has distal humeral fracture, supracondylar fracture, and when they have injuries, ischemia to the forearm muscle, and then these forearm muscle, they'll go into fibrosis and they cause contractures. So these contraction of the long flexors and the extensor muscle will result this kind of deformity. And this is a classic pattern. We call it Walkman ischemic contracture. Guys, this is a high yield concept. And you're expected to be good with this. Let's go further. Scapular anastomosis. It's very important. You have done in detail. Primarily, we all know the subclavian artery becomes axillary artery. There's a landmark. At the outer part of the first rib, it becomes axillary artery. And this axillary artery extends from my first rib to my teres major muscle. And it's coming up in my next slide. So primarily, I think we'll go there first. Let me show you here. Look at it. This is what we are looking at, the arteries of, I'll be visiting this picture again. So now, what is this? We have here arch of aorta. Arch of aorta is here, right? And from this arch of aorta, you're looking at the subclavian artery. Now, subclavian artery at this landmark, from here till here, this is my axillary artery. Now what happens? Beyond this part, this axillary artery, I have a muscle here, which comes from my, can you see this structure? Let me zoom in this image. This is my coracoid process. From the coracoid process, I have a muscle. which is attached to my upper three ribs. This is my pectoralis minor muscle. This pectoralis minor muscle divides my axillary artery into first part, second part, and third part. Are we good? So first part, very easy, give me one branch. Second part, give me two branches. Third part, give me three branches. Are we good with that? And then after the lower border of TD is major, this axillary artery, now we call it brachial artery. This is the brachial artery. And there it gives one of its deep branch, which is famous with the name of profunda brachii. You'll be learning the same name, same pattern in the lower limb also. That's why we are specific. We call him profunda brachii. In the lower limb, we'll be calling it profunda femoris. Anyway, some books also write this artery as a deep artery. Then this brachial artery, it runs in my arm region. You can see that this whole thing is my arm region. Now I'm reaching to my elbow joint region. And at that place, you can see that this brachial artery, it divides into two arteries. One goes to the radial side. So the radial side is my radial artery, and this is my ulnar artery. Are we good? Then you remember we learn about this radial artery. If you go down, you can have its pulsation. The normal, when people check on your pulses, the nurse, when you visit a clinic, the nurse look at here. She feel at this place. She palpate your artery mostly in this location. And then we learn about this artery, that this artery, when it enters my hand region, it pierces a muscle here, which is called my first dorsal interossei muscle. It pierces that, and then it pierces my adductor pollicis brevis muscle. And then it makes a deep arch, which is completed by a contribution from my ulnar artery. Are we good? So this is the deep arch. And then from there, it is joined with this arch, which is superficial to it. So we call him superficial arch. Now, who makes this superficial arch? Let's go back. Now you're at the ulnar artery. In this location, ulnar artery give another branch. Let me change the color because, or let it be. So this is my common interosseous artery. Common interosseous artery. This common interosseous artery, when it reaches to my interosseous membrane, what happens? This common interosseous artery in this location, it gives an anterior branch, anterior interosseous, and a posterior interosseous. One runs in the flexor compartment, and the posterior goes to the extensor compartment. Now my ulnar artery, when it reaches to my hand, it goes through, and there it makes one of its major contribution is this superficial palmar arch. And from this superficial palmar arch, my deep arch, where it supplies to my thumb pollicis, and one contribution to the radial side of my index finger. This is the contribution from my deep arch. Now, my superficial arch, it supplies, you can see that. Let me give it another color. So my superficial arch supplies on the ulnar side of my index finger, my middle finger, both the sides, my ring finger, both the sides, and my pinky, both the sides. So they all are getting their blood supply from this superficial palmar arch, and that is primarily a looping part of my ulnar artery. Are we clear so far? Guys, these are the important things. So this is a big picture for my arteries. If I want to look into that, what I was trying to show you, so there you can see that this image helps me with that. And there you can see what happens. There is, you are looking at the deep arch, and this is my superficial arch. And then you can see my deep arch primarily supplies my first digit and half of my second digit. But the remaining 3.5 digits, they are getting their supply from the superficial arch, and that is the ultimate part of my ulnar artery. Are we clear about this?
Yes.
Any question, anything which bothers you here?
Doctor, something else actually. Could you please make me co-host so I can allow the students to come in?
1 minute. Just wait. Lean, you want to be co-host?
Yes, please.
Okay. I'm taking a little bit time because I have opened a lot of screens. So I'm struggling a bit. Let me ask for a little help. Just bear with me a second.
First, take your time, doctor.
No problem. Because it's so long, we forgot almost. Because COVID taught us in detail about this Zoom thing, and now as I'm using so many devices, because I have things open in different locations, so then it'll be more functional. So I remember these three dots. Chat. I think meantime, when I'm getting the help, I'll continue my learning, and then shortly I'll be making you co-host. Don't worry. I know you have to admit people. Am I right?
Yes, there's a bunch of people in the waiting room right now, I think.
Okay, yeah. So 1 second. I have to make Lean co-host. I think they all are admitted. And Lean. Lean, the point is there is no co-host option in this. The person who's host that can share screen and all that thing. So probably I cannot make you co-host. That's the main issue.
Okay, I'll make you host and I'll try to fix the issue from my side. I'll try to find a
Okay.
solution.
Appreciate.
You're welcome.
Okay, guys. So a little bit technical glitch. So we are back. So what we are doing, we were talking about the overall blood supply. Let me quickly recap. We started from arch of aorta. Our journey continues from subclavian. Then we move to the axillary. Then we learn that axillary becomes brachial. And then this brachial gives a lot of branches in my arm region. When it comes to my forearm region, it bifurcates into radial and ulnar arteries. And this radial artery runs on my radial side of my forearm, and there close to the radius, and then we can palpate it distally as a radial pulse. This ulnar, which goes towards my ulna, we can palpate this ulnar pulse on the ulnar side. Normally, when we are recording a pulse, we are not bothered more for ulnar reason. Ulnar artery is behind this ulnar artery. There are so many muscles. So, guys, this is again a high point, and I remember somebody mentioned this question in the Google Chat document. And then I said, I gave you the task. Why you're asking me? So it's your task to find out where we can find ulnar pulse and where we can find radial pulse. Most commonly, the pulse which is recorded, it is at the distal part in my forearm, close to my radial bone. This is the common location. Ulnar pulse is less commonly looked for, but once we need it, once someone has an injury, some burn, or some other issue, or we are dealing from vascular kind of problem, then we need to go to the ulnar pulse. But normally, we are more concerned with this radial pulse. I hope we are fine. I try to talk about how my superficial and deep palmar arches are formed. Primarily, let me recap. The radial artery gives us the deep arch, and the ulnar artery gives us the superficial arch. Superficial arch is more functional. Even this deep arch, after supplying my first digit and half of my second digit, then it also have its contribution, which are blended with the superficial arch. So with this, let's go back. Now, this point, axillary artery, we talk about it. So what we have said, what is its beginning? Guys, we use this word where it commences. Guys, most commonly we ask this way. Give the, let's say I put some marker on this. Here, let me use a color which is visible to you. Let me put a marker here. And you're asked to identify the marked vessel. Give its commencement level and termination level. Commencement means where, at what place you start calling axillary artery as axillary artery, because we all know the axillary artery is the continuation of my subclavian artery. So, what is the specific landmark? Lateral border of the first strip. That's its commencement part. That is its beginning part. And where it ends, inferior border of the teres major muscle. So after these two, so it exists. So if I say this is my lateral border of the first strip, and this place is my inferior border of my teres major. So after this, I call this artery, if I draw it for you in this location, so I'll be calling it here as a brachial artery. And before that, I'll be calling it as a subclavian artery. So make no mistake with this concept. We commonly use the word commencement, where it begins. It's a very simple word, I'm sure everybody knows. And the muscle who divides it, you can see that. There you can see this pectoralis major, where this middle part is missing. So if we can fill in this whole pec minor here, pectoralis minor, not major. So pectoralis minor, it divides this artery into first, second, and third part. First part give me one branch, second part give me two branches, and third part give me three branches. Guys, this is important and quite commonly asked. So even if you remember yesterday during our TBL, we were talking about an artery which was lateral thoracic artery, and we give you a kind of scenario, and you are asked which artery primarily. What we were asking in that question, we were simply asking you name the branches of, if you know the artery is coming from the second part, then you did this right. Yes, I know most of you did this question right, and that was the point. So first part gives me superior thoracic artery, second part I have these two, and third part I have subscapular, and then I have anterior and posterior circumflex humeral arteries. Are we clear with this? So now let's go back to our previous slide where we were talking about anastomosis around the scapula. Now, when we need these kind of anastomosis, guys, during some interventions, during some accidents, during some kind of trauma, what happens? That we may have encountered, let's say you can see there's a clot. Can you see this clot? There's a clot which has traveled in my axillary artery. So now my second part is not getting, because beyond this no blood is flowing. Can you see any blood is flowing in this area? It's all empty. So now, if no blood is flowing, it means no blood is going to your whole upper limb. Beyond scapula, in your arm, no blood is coming. Means if you wait it like that, this person will not have any pulse. You cannot record his blood pressure. And if there is no blood coming, means the whole upper limb will ultimately, what happens? No blood, hypoxia, which leads to anoxia. And then that leads to what? Gangrene. It turned blue to black, and then you have to amputate this limb. So how we can get rid of this problem? But before we intervene, the one who made us, he has made so many arrangements, so many collateral channels. Now, if you can look back, you remember we talk about that axillary artery starts from this level. But before that, if you look at this artery, the thyrocervical trunk, it gives two contributions. One is a deep branch of my transverse cervical, which is also famous as dorsoscapular artery. So you can see this guy, it's coming all the way down. It's coming up and it's joining here. And then we have suprascapular artery, which is also a branch from my thoracocervical trunk. And that is coming from this location. Now they are joining with what? This is which artery? Subscapular artery. And you remember what we said, subscapular artery is branched from where? Do you remember that? Subscapular artery was a branch from my third part. Are you fine? So now you can see that they join here. So fine, blood is not coming from this channel, but blood has rerouted himself, and now we can have blood flow. So some blood is, well, it doesn't mean that now this is end of the story, the person can live normally. No, it will be a compromised kind of living. But now what will happen? The person will get some time. He can be brought to the ER, and from there, you can take him to a vascular surgeon. And usually we do a procedure. We just insert a cannula, which is called Fogarty catheter, and then we can dislodge this clot, and then the flow of the blood is being restored. Normally, not being making major, because we cannot cut the whole artery. So we enter through the subclavian route. We push this tube, this kind of thing, which goes in. It has a balloon. I'm not going into this detail. Sorry. Let's not talk about surgical intervention here. It's not for you. But simply remember, we insert a device which comes all the way, a flexible device, and with the help of that, we can dislodge this clot. Once this clot is being removed, is being dismantled, so now the normal flow of the blood will be restored, and then person has fine normal flow. And then after a few days, you can send this person back home for his normal living. So anastomosis of scapula, what is its significance? If we have some kind of problem, but obviously we have limitation. If it's beyond, if it is not, if that's say I have a clot here, then I have more issues. So there are so many things, but there are few places where we have some kind of window period. I hope we are fine with this. So where we were talking about axillary artery. We talk about what is its commencement, and we talk about what is its termination. And I'm sure everybody knows and understand when we use the commencement, what we want from you. Primarily, the biggest problem, why we lose marks? Because you don't understand the terminology, and that's the main show. So if you are good with these two words, and then you are good with this, I know you memorize it very easily. It's not a rocket science. First part, one branch, second part, two, third part, three. Are we done with this? Yes. So now let's move to the veins of my upper leg. So veins, what we can see here, when we talk about veins, we start from these arches. The arches are there on the dorsum of my hand, and you can see veins. If you look at it into your own hand, in the prone position, you can see there's a bunch of veins. And these veins from this dorsal venous arch, they continues as on the radial side, we have cephalic or cephalic vein, and on the ulnar side, we have basalic veins. These veins, they are going up, they meet in the cubital fossa in this area. Let me change the color because we're talking about veins. So in this area, they are bridging, and there's a median cubital vein. And then you can see ultimately my cephalic veins, it runs in the deltopectoral groove, and it ultimately, my basalic and cephalic, they are going. My basalic vein continues as my brachial and axillary vein, and then this cephalic vein drains into that, and then this axillary vein becomes subclavian, and subclavian joins with the internal jugular and give us vice versa. And then we have brachiocephalic, and then we talk about that in CVP block. So this is how these are the superficial veins of my upper limb. We have deep veins. They are vena comitans. They surround the big vessels. We'll be learning separately, not now. So I hope we are good with this concept. Now, let's come to this very important concept, very high yield topic, and we love to ask this a lot of time. Brachial plexus. Those of you, I'm sure all of you have visited your lab. Remember, anatomy is all lab. Lecture, we can give you some shows, but primarily the lab is the prime place for your learning. And almost, I'm sure, all of you have seen these roots of C5, C6, C7, C8, T1, and then we learn about how the brachial plexus is being formed. If I'm sure everybody knows we have these roots, then they join, they give us the trunks, upper, middle, and lower. Each trunk will divide into anterior and posterior, anterior and posterior. So my all posterior joins to give me the posterior cord, and then I have lateral cord and medial cord. So what is the level? What is my criteria of calling them lateral cord, medial cord, and posterior cord? If we go back to our this picture here, if you look at into this picture, can you pay attention? There you are looking at, this is my, which artery? We call him axillary artery. So medial to it, can you see this green color structure here? That was my brachial plexus. And there you can see musculocutaneous nerve. So musculocutaneous nerve, we know it's a continuation of my lateral cord. And then we have the medial cord, and posterior cord you can see is going behind. So basically this artery, the axillary artery, on the basis of axillary artery, any nerve which is lateral to it, we call it lateral cord, medial to it, we call it medial cord, and the thing which is posterior to it, we call it posterior cord. Are we fine with that? So this is the basis. And then we know it, the lateral cord continues as the musculocutaneous nerve. The medial cord continues as the ulnar nerve, and the posterior cord continues as radial and axillary nerve. Let's say a few words. In my arm, we have two compartments. What are these two compartments? Flexors and extensors. So my musculocutaneous nerve, which is actually what? The lateral cord. This musculocutaneous nerve, primarily, it is responsible to supply coracobrachialis, biceps brachii, and brachialis muscle. And then it continues as lateral cutaneous nerve of the arm and forearm. That's it. This is all about my musculocutaneous nerve. Then if we look at it, my lateral cord, it gives lateral root, and my medial cord gives medial root. And they are making a median nerve here. And this median nerve, primarily, is the nerve of my flexor. Flexors of the forearm are controlled mainly by this median nerve. And when it reaches to my hand, there it supplies the thenar eminence muscles, the muscles who are controlling my first digit, my thumb, my pollicis. That's the prime motor supply of my median nerve. This will be my median nerve. And this ulnar nerve has no contribution in my arm region. In the forearm region, it has little. Flexor carpi ulnaris muscle is innervated by this nerve. And then it supplies the digit 4th and 5th of my flexor digitorum profundus muscle. But primarily, when it enters the hand, guys, if I say all the muscles of the hand are innervated by ulnar nerve, except for my 4th and 5th flexor digitorum profundus, tendons, and my lumbricals. Two of those lumbricals, which are attached to these tendons. Rest of my whole hand is supplied by ulnar nerve. Are we good so far? So this you should remember. Now, when we look at this brachial plexus, what happens? At the time of birth, we divide this plexus into two. We said upper plexus, we said lower plexus. And if we have injuries occurring to my upper and lower plexus injury, there's a up point, we call it up, Duchenne paralysis, and the down one, the lower part of my plexus, we have Klumpke's pattern of paralysis. So these are the paralysis, these are the injuries if they occur at the root levels. Then we have at the up point and this point. So these are happening at this location. And then as we go on, if we have injuries here, if we have injuries here, if we have injuries here, we have different subtypes. And then when we come to the main nerves, so these nerves, once we have injuries of these nerves, then we'll be learning those. I mentioned about musculocutaneous nerve. I mentioned about median nerve. I mentioned about ulnar nerve. I did not mention yet about axillary nerve and the radial nerve. Axillary nerve is a branch from my, can you see this green one? That is my posterior cord. So this posterior cord, one of its major branch is axillary, and axillary is primarily confined to the shoulder region. Within the shoulder region, it controls and supplies my deltoid muscle, a big muscle, and then it supplies my teres minor, and then it gives some sensory supplies which is over the skin, laterally placed. Simply they say the badge area, where the soldiers, they have their badge on their shoulders. That's the place where they have a cutaneous branch, a sensory branch from my axillary nerve. Now the radial nerve is a big nerve. Radial nerve primarily in it supplies the extensor of the forearm, whose that is the triceps. Then it comes down in my forearm region. It supplies the extensors through its deep interosseous, and some of the muscles are innervated by its superficial part. Superficial part continues down to my hand, and the posterior interosseous nerve supplies my deep muscles of the extensor compartment, and that's the whole fate of my radial nerve. So we have primarily covered or visited these peripheral nerves. We learn them as peripheral nerves, and then we'll be learning about injuries of the peripheral nerves. That is upcoming. That is in my next slide. So brachial plexus injury, I talk about Duchenne paralysis. And what was the area? If I have injury to C6, C5, and C6, and usually birth-related injuries, it's quite common that when you're delivering a fetus at that time, and normal delivery is the head come first. And when the doctor and the nurse, if they are struggling, and if it's kind of an obstructed labor, there are fair enough chances you may stretch when you're pulling, when you're holding the head of this baby. I will not say the baby fetus. That time, if you give extra stretch or you're doing some instrumentation, and if this C5 and C6 roots are involved, so that is considered as upper trunk of the brachial plexus, and that is, there's a specific area, Erb's area, and then patient present with Duchenne paralysis, and they have a very classic appearance. Their hand goes by the side, it's medially rotated, and it's a finger, the waiter tip kind of deformity. There are so many names, and I'm sure this must have been covered well in your lecture, but this is a high yield. The high yield, I'm just marking it. This is an high yield area. Second, Klumpke's paralysis. This is the lower plexus. In the previous slide, I've shown you, this is the lower plexus. What happens if you pull someone's arm? Sometimes there is an abnormal presentation of delivery. So the body parts come first. Let's say you're pulling at the arm, or somebody is falling from a height, on the way going down to the floor, holds some tree, and there's a sudden stretch. It might result in injuring my lower part of the plexus, and that is classically famous as Klumpke's paralysis, and this has a lot of presentation. Guys, we have ptosis, pupillary constriction, ipsilateral anhidrosis, because it's associated with Horner syndrome. And I'm sure you are familiarized with Horner syndrome. Guys, this Horner syndrome, again, a high yield topic. Please don't ignore the word high yield. And we usually ask this quite frequently. Are we good so far? If there is any question, I will wait, otherwise I'll proceed. I don't see anything emerging in the chat. So now let's come to the individual nerves. I have mentioned a lot of them, but let's have quickly. Guys, you can see the different presentation, and what has been said. If the injured nerve is the axillary nerve. So every spinal nerve, remember, plexuses are formed by the ventral rami. I'm sure everybody knows what is ventral rami and what is dorsal rami. Plexuses are formed from the ventral rami of our spinal nerves. And each spinal nerve has a motor, sensory, and sympathetic component. What for motor? For the muscles. What for sensory? Sense of touch, pain, perception. Sympathetic. Don't you have blood vessels? Don't you have glands? Don't you have, when you are in a state of fear, these hairs, they stand. Who does it? All sympathetics. So, if this nerve is damaged, which nerve we are talking about? We are talking about this axillary nerve. If this axillary nerve is damaged, so when we say this is the root value, guys, C5 and C6 is the root value. My axillary nerve is damaged. If it's damaged here, I'll get no contribution to shoulder joint. And then its motor contribution. It supplies what? It primarily supplied my deltoid and teres minor muscle. So these two muscles will lose their function. And if I have sensory deficit, so there I'll have a badge region. I mentioned on your laterally superior aspect of your shoulder, laterally a badge area, badge region. So in that area, you lose the sensation. So there you can see how this axillary nerve, and these are the consequences. So if you injure here, you lose this function, or that function. Guys, for this, if you are good with this image, you're knowing everything. And if you match with the motor and sensory deficit, you're good with this situation. Guys, axillary nerve most commonly asked, especially in association with surgical neck, in association with dislocation at the glenohumeral joint. So it's a high yield area and very famous for being asking. Coming next, musculocutaneous nerve, which was the continuation of my lateral cord. So this is the root value of this nerve. And you can see it runs here. How I identify musculocutaneous nerve? If I look at medially placed in my upper arm, this muscle, coracobrachialis, a nerve which has been seen piercing this muscle, that is nothing but my musculocutaneous nerve. And this musculocutaneous nerve, primarily, it controls the motor contribution is after coracobrachialis, it's biceps and brachialis. Then it continues as lateral cutaneous nerve of the arm and forearm. There's nothing worth here which you can see a lateral cutaneous nerve of the arm and forearm. Now let's come to the median nerve. We talk about it. We have lateral root and median root to median nerve. We saw it in the brachial plexus. If you remember, this was the one. And then, as I mentioned before, this median nerve, you can see there, has no contribution in the shoulder region. No contribution, no primary contribution in the arm region. Only it supplies a little bit to pronator teres. It enters the forearm, and primarily it controls the flexor muscles of my forearm. Are we good? So this is all about the median nerve. This median nerve, you can see that it also gives a deep branch, which is famous with the name of anterior interosseous branch. And this anterior interosseous branch is primarily supplying the deep group muscles. Who are the deep group muscles? Flexor digitorum profundus, pronator quadratus, and flexor pollicis longus. And there you can see this image is really helpful in just going over. So you can see that its primary supply within the forearm, and there you can see its anterior interosseous branch where it supplies, and then these are the supplies to my superficial group of muscles along with the intermediate. So superficial and intermediate are getting their direct muscular branches from the main median nerve. But the anterior interosseous is primarily responsible to supply the deep group of muscles. And then this one, when it goes through enter into the wrist, it crosses the wrist joint, it gives this recurrent branch. This recurrent branch, it supplies my thenar eminence muscle. These are three muscles. And then you can see it also supplies the first two lumbricals, and then it also have contribution to the tendon of my second and third flexor digitorum profundus muscle. So that's the sole supply of my median nerve. If this nerve is cut here, all the supplies are gone. Let's say if this nerve is cut in this location. So only I have losses in the hand. My forearm muscle will not be affected. This point you need to be very clear. Okay, if this nerve is damaged before giving this branch, if it's damaged here. So the area where it is damaged, distally, everything will be lost. But beyond, if we damage it here, now it may supply few of my superficial compartment or intermediate muscles, but my deep ones are all been cut. So this helps you how to understand the whole concept of this nerves. Are we good? Let's go further. Let's move to the radial nerve. Radial nerve, we talk about it, that this nerve is what is coming from my posterior cord. And this nerve is primarily, you can see it's running in the spiral groove. So if we have fracture here, this radial nerve is gone. And once it is gone, then we'll have problem with our wrist joint. We have wrist drops. But make sure, see, if it's fractured here, there is one branch which goes to my tricep is being still intact. So part of my tricep will still function because the fracture is happening here. But this nerve is fine. So the part of my tricep which is controlled by this branch, which is given before this nerve enters this radial groove, that is still working. So make no mistake and try to understand. And then you can see it comes down, it supplies in my extensor compartment, and there it gives, you can see this muscle, then it's basically it going, pierces the supinator, and then it supplies the deep muscles in the extensor compartment of the forearm, and here it's superficial, so very little contribution from my radial through the radial, but primary contribution is from my posterior introsseous. So make no mistake with these concepts. If we come to this diagram, which is very helpful for learning a lot of things, I was talking about this branch. If I have injury in the spiral groove, still my long head of the tricep will be functioning. So that should be very clear in your. In the forearm, you can see that. What are those muscles? So these are the all. This is the arm region. So all contribution will be gone, and then this is the sensory branch. And here, when it enters the forearm, the superficial branch supplies little, but the major contribution are from the deep branch of the radial nerve. So make no mistake with that. If we have injury at this level, we'll lose only these functions. But if we have injury at this level, all these muscles, all these extensors will not be able to do what they should do. Are we good so far? So let's go down to the ulnar nerve. I told you the ulnar nerve, its main job is to control in my hand. It has no contribution in the shoulder region. It's not doing anything. In the arm, is not doing anything. In the forearm, it has very little supply to flexor carpi ulnaris, and then it supplies fourth and fifth digits of my flexor digitorum profundus. But when it enters the hand, and there you can see a lot of supplies are coming from my ulnar nerve. And then a famous ulnar claw and all those kind of things are associated with that. Are we good so far? And there with each nerve I'm mentioning what are the motor deficits and what are the sensory deficits. Now, these three pictures are depicting if we have radial injury, what kind of sensations will not be, because this is displaying, you can see the wrist drop and you can see the sensory loss. Median nerve, we all know, in my hand, 1, 2, 3.5. So 3.5 digits, they lose their sensory supply. If I just feel the sensations in my hand and in my digits, I will not find the sensations, the sensory component, because if I have injury to the sensory part of my median nerve, I will not be able to find sensation. So I can just check on the sensation, and that gives me a clue I have an injury to the cutaneous part of my median nerve. And if I come for the ulnar nerve, you can see that 1.5. So 1.5, my digit fifth and half of my fourth, they will lose their sensory supply. Guys, these sensory or cutaneous supplies and their check is really important in the clinical setting, and you need to be good at it. Now, so we have covered by doing this the arteries of the whole upper limb, and then we have talked about all the nerves and their associated injuries. I have not gone into the details of the test because I told you this is a review session. It's not like you have in your formal lecture you have been taken into the thing. So now we are talking about another important joint, sternoclavicular joint, a very important. This joint, what type of joint is this? We all know it's a synovial. Which type of synovial? What is subtype of synovial? It is a saddle synovial type of joint. And guys, this table, I mentioned to you many times. What you must know in a joint. What is the type of the joint? It's all written here. Who are the articulating surfaces? You should be good at that. What type of capsule are encountered? And the main thing, what are the ligaments? You can see that anterior, posterior, sternoclavicular, right? Interclavicular and costoclavicular ligament. Who is the stabilizing factor? That's really important. So in every joint, if you learn the joint under this 1, 2, 3, 4, and 5 and 6 headings, you will not be missing anything. Be rest assured. If you know this much, you are doing a good job. But if you are compromising on something, and the most important thing here, names of the ligaments, who is the stabilizing factor? So this costoclavicular ligament is the mainstay. If you remember the undersurface of the clavicle, medially, we talk about a connection, a ligament which exists between the medial end or the sternal end of the clavicle and the costal cartilage below. That's why it's called costoclavicular ligament. I told you this costoclavicular and coracoclavicular ligaments are stronger than my rib. So they damage after, but my rib fracture first. And then what movements are occurring at this joint? So these are the, so about a joint, if you don't know these 6 headings, then it's not a good idea. And joints are always high yield. Simply remember, in my upper limb, I have 3 major joints, and then there are some minor joints. In my lower limb, I have 3 major joints. So what are the 3 major joints in upper limb? Number 1, glenohumeral or shoulder joint. Number 1. Number 2 is elbow. Number 3 is wrist. Then the minor joints are sternoclavicular, acromioclavicular, and then we have some joints in the hand region, across the wrist region. But the main joints where you are not expected to lose anything, you'll be must to know minimum is this. Guys, minimum is this. And if you learn more, you'll be much better off. So what joints your prime focus should be? It has to be glenohumeral joint, which is the shoulder joint, elbow joint, and the wrist joint. Now, let's go down. Now I'm at the, which part of the chest I am? I am at the shoulder region. And in the shoulder region, if you look at it anteriorly, we have 2 big muscles. And you can see in this image, on this side, you're looking at the pectoralis major. Guys, this pectoralis major is again a high yield subject. Is a high yield. Don't miss pectoralis major, ever. What you must know about pectoralis major, its attachments. Guys, you have asked a question regarding how much you know from origin insertions. Guys, nowadays we talk about proximal and distal attachment, and whatsoever is mentioned in the slides provided by the people who are teaching you, I think whatsoever is written in those tables, that is a must know. So no compromise, nothing is less than that. Even if you go into my lectures or Dr. Olina's lecture or Dr. Vlad's lectures, you'll find these tables which are talking about, I'm writing at proximal and distal attachment. They are writing at origin insertions. These origin insertions are quite similar to proximal and distal attachment. We are not going in detail those things. So this what has been mentioned in these tables, it's a must-know thing. So there is no compromise, and don't stop anything. Otherwise, you might be facing some kind of issues. And pectoralis major is one of the high-yield muscle. You are expected to be best. I'm not saying good, best at its attachments, both proximal and distal, its actions, that's the mainstay, and the nerve supplies. And what are the consequences if this nerve is damaged? Make no mistake with pectoralis major. And there you're looking at. When we remove this pectoralis major, you can see that pectoralis major has been cut in this location. And under that, we have this guy. That is my pectoralis minor. And this pectoralis minor was the one under which we have the journey of the artery. Which artery? Axillary artery. And this muscle we use it as a reference point. Above to this muscle, we call it first part, second part, and third part of my axillary artery. So make no mistake. Then if you look at, if I zoom in this image, on the side, I think better shown on this side, serratus anterior. A very one of the most commonly asked questions, specifically controlled by long thoracic nerve, which comes from the root. If you remember, this was the question asked during your TBL. Yes, expect more. Serratus anterior, winging of scapula. So they all are connected. Usually, when we are removing a breast of a human, mostly the females, breast cancer is one of the common thing. When we are doing surgery, especially when we are doing mastectomy, removal of breast is called mastectomy. When we are removing a breast, long thoracic nerve is susceptible to be damaged, and this long thoracic nerve, which emerges from the roots of my brachial plexus, if that nerve is gone, that serratus anterior muscle will loses its function, and when it loses its function, one of the clinical manifestation will be winging of the scapula. So, anterior chest wall and lateral chest wall, pectoralis major, pectoralis minor, and serratus anterior, there is no excuse. Don't miss any one of them. Pectoralis minor, more associated with when we'll be learning axillary artery and its branches, and this pectoralis major and serratus anterior as a whole are high yield things. Then, if you look at here, this deltoid, again another high yield muscle. Are you good so far? Guys, I'm just talking high yields. Now, if you come to the back, on the back, we organize the muscle of the back in two layers, the superficial muscles and the deep muscle. Now, if you look at the superficial muscle, if you pay attention here, can you see that this big guy, which is a diamond-shaped muscle, present on both the sides, this side is being cut. That's why you don't see it here. So this half of this is my trapezius, one of the superficial. And can you see this muscle here? This big muscle, that's my latissimus dorsi. This is also called swimmer muscle. This is my latissimus dorsi. Because we have removed this trapezius, so you can see all components of this latissimus dorsi muscle. Then, when we go deep in, when we cut this, so you see on this side, when we cut this muscle, there you can see under cover of this trapezius, we can see these muscles which are attached to the medial border. This is the medial border. Some books also write it as the lateral vertebral border of the scapula. This muscle, levator scapulae. From the root to this area, rhomboids minor. Let me change the color. And this guy is my rhomboids major muscle. Make no mistake. Then you're looking at supraspinatus and infraspinatus. You're looking at teres minor and you're looking at teres major. So these are inclusive in the deep group of muscles. Guys, make no mistake. Can you see there's a triangle being formed here? If I zoom in this area, by the crossover of these muscles, there's a triangle formed here. This is my triangle of auscultation. Usually, when physicians are trying to listen to your chest sounds, they are always coming from your back. And this is one of their hint. In this area, this is not much covered by muscles, so you can directly coming in contact with the posterior chest wall and you are listening to the lungs. Are you clear so far? Guys, my triceps, my trapezius, my latissimus dorsi, my deltoid are high yields. And then this supraspinatus, infraspinatus, teres minor, and subscapularis, they are important in what sense? They are important in rotator cuff muscles, the stabilizers of my shoulder joint. And then supraspinatus itself is very high yield muscle. Reason why it's so high yield, because the tendon of the supraspinatus is always in a trouble when we have some skeletal related issues, some bony kind of diseases, some disease of the bone and the soft tissue. So this tendon of this supraspinatus is under in problem. Once this muscle is damaged, initiation at the shoulder joint is being compromised, and then this is the first manifestation, and then it leads to a lot of things. There is a lot of things, and I remember last MSK exam we asked about impingement syndrome and a lot about the painful arc syndrome. So they all are associated, very closely associated with supraspinatus. and you are expected to be good with that. Trapezius, its action, its beauty, its nerve supply, it's supplied by one of my cranial nerve. So spinal accessory is the nerve which controls my trapezius muscle. And it's a diamond shaped muscle. If I draw on both the sides, so I have drawn it a little over. So this is a complete kind of diamond, they call it. Now, this is again, I remember people must have been making using their fingers, and when you might have visited your labs, people have talked about a quadrangular space. And then can you see there is one triangle here, another triangle here. So primarily, what you are expected to know about these spaces, they are present posteriorly. You're expected to know their boundaries and what are their contents. So this is how this is in high yield in term of your upcoming things in TBLs and in finals. We ask about these spaces, their boundaries, and the structures who are piercing it directly or indirectly. You are stabbed in this area and you lose this function, that function. So that's why it's really important to know about its high yield. And also here in this image, you're looking at the supraspinatus muscle, infraspinatus, teres minor, and teres major. Are we good? So make no mistake in the shoulder region. Now, another very important landmark, and that's the axilla. What is the axilla? Guys, axilla is a pyramid-shaped structure. I'm sure everybody knows what is a pyramid. Primarily, this axilla is a pyramid-shaped structure which starts from your neck like this, and it enters at your armpit. And then this is the axilla, and primarily it transmits the neurovascular bundle either from the neck to the chest wall and to the upper limb or vice versa. Are you fine? So now what has been done? This picture, what is demonstrating to you? If we are looking from a side view, this is what you'll see. This is a trapezius. Can you see trapezius is here? And then you can see anteriorly, what is this muscle? This big muscle is my pectoralis major. And there is a tiny muscle. You remember at the clavicle we talk about there's a groove on the undersurface of the clavicle. There's a muscle called subclavius that lives there. And then there's a fascia which extends from the margins and then it goes down. It encloses your pectoralis minor muscle. Then it comes down. And this is the skin of your armpit. What is armpit? In your axilla, the place where you grow hairs. Your secondary hairs, which are being grown in your armpit, which usually we shave. So that is the armpit. So this is how. So this is the lateral view. But now if we have a transverse section, so what we can see on a section, you can try to understand this. So let me zoom in this image. You're looking at the humerus, scapula means we are at the back. This is the front. This is the anterior. This is the posterior. This is medial. And this is lateral. So if I want to really make out axilla here, I can use blue color and let me draw it for you. Can you see this? So this is a transverse section of my axilla, and you can very clearly make out who is anteriorly, what are the anterior boundaries, what are the posterior boundaries, what is the medial boundary, you know the muscle, you know this muscle, you know these muscles. And what is the lateral boundary, you know these structures. And then once you know the boundaries, then you are expected to be able to answer the contents, the structures, who lives, basically who are traveling through my axilla thing. And these structures are, you can see that, who is this? These are the infraclavicular part of the brachial plexus, and this is my axillary artery. And we told you, in relation to this artery, we said this is the lateral cord, this is the posterior cord, this is the medial cord. Are we good? This is the axillary vein, that's the axillary artery. So if somebody asks you, what are the contents of my axilla? So simply, you can talk about these major structures. So we can see that who are the structures making the medial wall, who's making the lateral wall, who's making the posterior wall. So this is how you have to answer. And you can see here, this was a side section, a transverse section, and these are primarily the contents, the structures who travel through this area, which is called it as axilla. Are you fine? So now let's move further. Shoulder joint. Shoulder joint, very simple. It is primarily a joint, a synovial type of joint, ball and socket. And this is the socket, which is the glenoid cavity. It is reinforced by side. Let me use another color. On its sides, can you see this darker color structure? That's called the glenoid labrum. And there you can see the long head of my biceps, it comes like this. And if I place my head of the humerus, it comes somehow like this, right? So it makes a ball and socket type of joint here. Then primarily, this joint is covered by a capsule. And within the capsule, we have glenohumeral ligaments, and these are superior, middle, and inferior primarily. And then you can see this, the long head of the biceps is coming over, and there you're looking at the rotator cuffs. See, this joint is surrounded. From the top, it's well secured. From the front, is well secured. Posteriorly, it's well secured. So this is posterior, this is anterior. It's well secured. And then inferiorly, there is no one. It's empty here. So that's why most common dislocations are inferior. Anything which happens, if there is any injury, if you fall on your shoulder, so your head of the humerus will come down first. And then mostly it goes, this is the posterior aspect, this is the anterior aspect. So we have first inferior, then anterior. This is the most common pattern of the dislocation occurring at my shoulder joint or my glenohumeral joint. Now, one more point. When this head of the humerus get out of this area, what happens at that time? My axillary nerve is here. When it's getting out of this, it hits this axillary nerve. And if axillary nerve is gone, I will lose the functions. We all know, we talk about it. Another problem. Someone has a dislocation occurring at the shoulder joint. When you try to relocate, you may damage this nerve. So one has to be very careful, even when you receive a person to whom you diagnosed it as that this person is having dislocation at the shoulder, always document and check for the existence or the functionality of the axillary nerve. If it's not, axillary nerve is not functioning, how you can check? You can check for general sensation, then you look for the muscles, the movements, and if you cannot do it, you'll be in a trouble. Because person may have come with a damaged axillary nerve. If you know it, you can fix it. And especially when you're relocating. After relocation, again check for the axillary nerve, because this nerve is located inferiorly. And when the head get disengaged, head of the humerus get disengaged from the glenoid cavity, it hits this structure which is living, which is the first resistance at the inferior part of the of this joint, because it's well secured superiorly, well secured posteriorly, well secured anteriorly, but it has no obstruction. It has no one is stopping this head of the humerus when it leaves this space downwards. So this nerve can be traumatized. So as I told you, when you need to look into any joint, first look at the type, synovial, ball and socket. Are we good? Now the socket was very shallow. So to make it deep, we have this glenoid labrum. And then rotator cuff muscle are the stabilizing factor. Articulating surfaces, we know it. The glenoid cavity of scapula and the head of the humerus. We had a capsule. Inside the capsule, we have these ligaments, superior, middle, and inferior. Then we have a transverse humeral ligament, which keeps this long head of my biceps muscle. And stability, primarily the rotator cuff muscles. And then movements, We know the movements at the shoulder. We have flexion, extension, abduction, adduction, medial lateral rotation, and circumduction. So all these movements are occurring at my shoulder joint. Guys, the shoulder joint is high yield topic. Always asked. So shoulder dislocation, it's all written here. You can read it. Supraspinatus tendon rupture, painful arc syndrome. It's important because if you look at the supraspinatus, and I'll be covering this concept in my clinical anatomy lecture, painful arc syndrome and supraspinatus tendon. Guys, last year, MSK final SEQ was on this topic. So we need to be focused on this topic. It's one of the high yield area. Primarily, shoulder joint is unique. Mostly, the joints are formed where we have bones. Bones are connected together by ligaments, and then they are covered in capsule, and then they are surrounded. But the shoulder joint is unique. There are bones in, then we have muscles, and then we have bones again. So muscles are sandwiched between the bones. So which muscle is primarily the supraspinatus? So once we have long wear and tear, and shoulder joint is one of the most movable, one of the most problematic during sports and all associated injuries. So because the supraspinatus tendon is sandwiched between the bones above to it and under it. So this muscle is quite prone to a lot of problems. And then once this muscle is involved, then we have some bursas here. And once they are involved, we have a big trouble. And you need to learn a lot about it. And I'll be covering this content in the lecture where I'll be talking about clinical anatomy of the upper limb. And then again, my second lecture of kinesiology. And I'll be discussing in thorough detail about the shoulder joint, and there I'll be spending a lot of time, a good time, only the understanding the biomechanics and everything related to my shoulder joint. So you are expected to be highly connected with this. Coming down, looking in the arm, we have talked about it, nothing new. We talk about median nerve, we talk about brachial artery. You can see that it's running, and these muscles are biceps and the other muscles, and then it's going to my bicipital aponeurosis. This is where what is the structure? We call this structure as the cubital fossa. I don't see any thing which bothers us here. Now coming to this joint, elbow joint. So elbow joint, and then the other heading is superior radioulnar joint. So elbow joint, primarily the lower end of the humerus and radius and ulna. I mentioned is a complex type of hinge joint because we have three pattern of articulation. If I draw it for you, bear with me my drawing. So this is my lower humerus. This is a free hand, guys. So we call this as trochlea, capitulum, medial epicondyle, lateral epicondyle. And then vice versa, we have underneath ulna bone and radius is here, right? So we have an articulation between this. Let me use another color, trochlea and trochlear notch. So humero, ulnar articulation, radio, humeral articulation. And then we have another articulation between the upper ends of my radius and ulna. So, and this all of these guys, they are enclosed in a capsule. Are we good with this? When we were learning this, I think I used some kind of picture like that. Now, very simple. If I erase this capsule to make our life easy, so let me insert one ligament. This is my lateral side or radial side. I have a ligament which extends radially. This ligament, I call him, what should I call him? This is my radial collateral ligament. And then I have a ligament on the ulnar side, and I call this ligament as ulnar collateral ligament. These are the two primary ligaments. You can see here. And they are very clearly shown in this picture. The medial ligament. What was the medial ligament? Ulnar collateral. You remember we talked about it. It has 3 bands. And this is my lateral ligament. Can we see that? So these are my those ulnar and radial collateral, and they are being shown. So this is, you're looking at, this is my radius. This is my ulnar. So this is my ulnar collateral. That's my radial collateral. Are you fine? And this joint, this is where we have the head of the radius, and this is the ulna. So that is the annular type of ligament. So if we try to dissect, if we try to go into this joint, the elbow joint, who is the articulating surfaces? Capitulum and trochlea of the humerus, head of the radius, and trochlear notch of the ulna. Ligaments are ulnar collateral and radial collateral. Stabilizing factor because of the articulating surfaces and the collateral ligaments and muscle crossing over. And what movements we are getting over? We are having flexion and extension. So, by our formula. Then coming to this joint, superior, I'm not mentioning here inferior radial ulnar joint. So this is a synovial pivot type because the long axis goes like this. And I get pronation and supination at this joint, at the lower joint. So what type of joint is this? Pivot synovial. So who are the articulating surfaces? Round head of the radius, and then a fibrous osseous ring formed by the radial notch of ulna and annular ligament. So annular ligament and the chordate ligaments are the ligaments, and mainly due to the ligaments, these ligaments are strong and they keep this head of the radius. You remember I told you less than age 5, this annular ligament is not developed properly. So the infants in this age, if you are not careful, while you're pulling their arm over elbow, there is chance you have pull elbow situation. Guys, this is a high yield topic. We love to ask it quite a lot. Specifically, this superior radioulnar joint, the dislocation which occurs at my elbow joint is posterior dislocation. Are we good? So guys, make no mistake. Now we are coming to the forearm muscles. You remember for the forearm muscles, we divided these muscles into 3 groups. We have talked about superficial group, we have talked about intermediate group, and we talk about the deep group of muscles. And there you can see very clearly the mainstay is medial epicondyle. From the medial epicondyle, we can have pronator teres. Do you remember with the pronator teres, I talk about a nerve, my median nerve. It passes between the 2 heads. So pronator syndrome, high yield. Pronator teres. Then a muscle from the common flexor origin going to the radial side to the second digit at its base, flexor carpi radialis. Palmaris longus. You may have it, you may not have it. And then flexor carpi ulnaris. These are the 4 muscles which we learned and we have seen in our labs during our, for these superficial flexor group of muscles. When we move to the next muscle, then we learn about one muscle only, the intermediate zone, and we know it. It's been, you can see it's coming from medial epicondyle, from my ulna, from the interosseous membrane, and from the radius. If you can see its attachments, so it's all the way this humongous attachment. And then it comes down and then it splits in 4 tendons. And these 4 tendons, they go and attach. If I draw it here for you, let's say, let me change the color. This is my distal phalanx, my middle phalanx, and my proximal phalanx. So this muscle, its tendon, when it comes, it attaches, it splits in 2, it goes like this. So this is the pattern of this tendon and get attached on both the sides of my middle phalanx. Because through this, who crosses? I have the long tendon of the flexor digitorum profundus. So it give way for that. That passes through this gap and get attached. So this was my intermediate group. And this last one, you can see here someone down. Can you see someone is nicely visible to you? But it's covered. So this one was my pronator quadratus. And then this guy, radial side, this is going to my thumb. Which part of my thumb? Distal phalanx. So this is my flexor pollicis longus. And this whole big guy, which splits in four. You can see that 1, 2, 3, 4. This is my flexor digitorum profundus. Don't make a mistake. These two are innervated by median, and these these two tendons are innervated by ulnar nerve. So my flexor digitorum profundus shares double nerve supply. So we have seen in the labs, in the lectures, now in this session, all three layers of my flexor muscles or anterior muscles of the forearm. If you look at the pattern of the vessels, we talk about brachial artery. When it enters in the cubital fossa, it divides into ulnar and radial. Look at it. Ulnar is big. Radial is not that. So because ulnar has to do a lot of business in the hand, but radial is just has very little contribution as compared to the ulnar. See, then ulnar is the, because radial is not doing anything. So ulnar is the one which divides into common introsseous, and this common introsseous become posterior and anterior introsseous. Anterior introsseous is for my flexors of the forearm, and then the posterior introsseous is for the extensors of behind the introsseous membrane. And then you can see it comes down, it makes my superficial arch, and this guy makes my deep arch, and this is how the arches are made. And then what we can see here the pattern of the nerves. You can see here there is the ulnar nerve, there is the median nerve, right? And there you can see the radial nerve. Radial nerve has no contribution in the flexor side. It has contribution through its deep introsseous branch in the extensor side. Ulnar nerve has only supplying flexor carpi ulnaris and the two tendons of my flexor digitorum profundus. Then it's primarily meant for my hand. Are we good so far? Median nerve supplies the superficial layer, the intermediate layer, and half of my flexor digitorum profundus. It supplies my pronator quadratus and flexor pollicis longus through its deep introsseous branch. So median nerve is the main nerve here, here, and here, here, and half of this place. Are we good so far? Okay, so we are done with this. Now we are looking at the posterior compartment muscle. Extensors are arranged again in two layers. And then you can see here primarily the radial nerve. It's been seen piercing the supinator muscle, and then it becoming, it's a deeper branch, and then it's supplying all the extensors of my forearm muscle. And then it's almost done. It has no contribution in my hand. Now, when we cut at the lower end on the flexor side, when we look at the lower end of the flexor side of my wrist, we're looking at the carpal bones. So these are my carpal bones, and there is a structure. Let me give it some color. Let me make it. This structure is a band-like structure. We call him flexor retinaculum. And this flexor retinaculum, because of that, we have a space formed. So mostly the females are having a problem during pregnancy, and there you are looking at the two rows of the tendon of the flexor digitorum superficialis and profundus. Both of them are being shown here. So they all are inside. Only this flexor carpi radialis tendon is not in this space. And there is this flexor pollicis longus. And the one nerve is here. Remember, when we are talking about compartment syndrome, this is another example of compartment syndrome. For any reason, if there is a buildup in this space, this buildup of pressure in this space, women are primarily affected. So this increase in pressure, every pressure will go to median. So median, it supplies, that whole thing will be affected. We have severe pain. When you start working, the pain is there. And then we have loss of nerve supply, and then ultimately it destroys, and the thenar eminence muscle are in big trouble. So the only treatment, you just split this retinaculum, and then you're good to go. Okay, guys. Now this picture demonstrate to you. These are the flexor synovial sheet, and this is called the radial bursa. This is called the ulnar bursa, and these are the flexor synovial sheets, which are enclosing my digits of second, third, and fourth digits, and this encloses the long tendons of flexor digitorum, digitorum superficialis, and flexor digitorum profundus. So they are enclosed in that. Infection, when you're hitting some poisonous thorns or that thing, so they may travel, they can go back, and then you can have severe consequences. You have pus formation in your forearm region. High yield topic and very commonly asked question. And this has all been described here. And if we have inflammation of this tendon, we call it tendonitis. And if there's an inflammation of tendon plus the synovial sheet, we call it tendosynovitis. Now we talk about this. This you can see that the primarily the sensory supply 3.5 finger and this is 1.5 finger, the cutaneous innervation by ulnar and by median nerve. And now in my hand, I have this fine movement, abduction and adduction. What are these muscles? These are the intraossei, palmar, pad, dorsal, dab. So dorsal intraossei abduct, palmar intraossei adduct. Don't forget DAB and PAD. Palmar, P for Palmar, AD adduction. Dorsal, AB abduction. So this is how you can learn the function, and these are the fine muscles of the hand, intrinsic muscle of the hand. Now we are coming to this bone, which is the bone of, so we are done with this, with the upper limb. Let's move to the lower limb. Lower limb, hip bone, we have talked in ERP, so we're not going in that. Femur bone is the counterpart of my humerus. It has a head, neck, it has trochanter. You remember the humerus has tubercles. It has trochanters. This is the shaft, and these are the condyles. You're looking from the front, and you're looking from the back, and this is you're looking inferiorly. What is most relevant? What is high yield in this bone? That fracture in here. Remember, always how we ask, this is a very high yield topic. An old lady slipped in the restroom, mostly old lady, slipped in the restroom. Old ladies, osteoporosis is very common in them. Slipped in the restroom, unable to stand up. What goes wrong? What happens? She have fracture at the neck of the femur. Very common manifestation. Now, another variety, bikers. Nice weather, some drizzling, you're coming on the roads, the whole year. How frequently you see rain at Riyadh? Very less. So all the cars or the vehicles who are traveling, some oil is dribbling on the roads. When there's a little drizzling, some little shower, so now this oil is there. These bikers, they are in high speed, so they are highly susceptible to have some fall, and then these accident, we have injury between these trochanters, so we call it intertrochanteric fracture. So these are the two most common pattern of fractures. So this is my femur neck fracture, and this is my intertrochanteric fracture. Intertrochanteric fracture is the youngsters, bikers, that's the clue. And this femur neck fracture, mostly the old age people, and story is always slipped. And then when they slip, look at it, the fracture occurs. Now the mainstay, this is the normal picture you're looking at. Head of the femur, neck of the femur, and the trochanters of the femur. And look at this circle. This circle is very important. You can see the blood supply is going from here to the head. Guys, you can see also blood is coming from inside. This is a branch of obturator artery. But this is functional in younger age. When someone is 10-year-old, this is the main supply of my head of this femur. But when we grow big, this artery is being compromised. So now the main supply is coming from this circle, this anastomosis, this ring. And now if someone has fracture here, just see that. If someone has a fracture here, now this artery we said is being cut. Nothing is coming. If it was a younger person, he will sustain. But in old age, you can have this lateral and medial circumflex femoral arteries. They are done. And now no blood is reaching to the head. So this head will undergo avascular necrosis. It's a disaster. So usually when we have this type of fracture neck of the, you can see it in this pattern. It's showing you where you can see that how the arteries are going to the head of the femur. And once we have fracture here, you can see the fracture. So and now this artery is not bringing any blood. So no blood is coming to this head, and this head undergo avascular necrosis. We mentioned about avascular necrosis when we are talking about scaphoid bone in the carpal bones. There are so many variants. You need not to go in this. I'm crossing it. You need to be good at here, and you need to be good at fracture here. Intertrochanteric fracture is not that dangerous, but this fracture, because intertrochanter you have blood supply, but this head is done. Now what is the surgical intervention? We need to replace this head, and we have to do it, but the consequences are this head has to be gone because there is no blood supply. And then if you leave it alone, it becomes a nightmare. So very, if I have to write, I can put 10 VVIP. So make no mistake. And then how these people present, what is the status of their leg, their foot, and how their limb is internally rotated, laterally rotated. These are very high yield topics. Coming down. Another high yield topic. At my lower end of femur and upper end of tibia. This nerve. Old books write peroneal nerve. Now you'll find common fibular nerve. If you have been learning fracture, where? At the neck or head of the fibula bone. This nerve is gone. This nerve is gone, so you need to be clear. If we use this vignette, someone has fracture, or we are showing an X-ray where you're looking at the fracture of fibula, then think of common fibular nerve is gone, and then you should be knowing where does it supply. It's a high yield topic. Now, coming to the arterial pattern, this is an important topic. You remember when in ERP, when we were learning about that somebody is writing something, I can't view your screen, kindly can you check if the share screen activated? Thank you. 4:44 p.m. Let me check it, gentlemen. Write me back. Is it visible to you? I have just refreshed it. Just look at it. I hope it will be fine now. Anyways, so guys, what we are looking at here, you remember we talk about common iliac, which becomes internal iliac, which we use for supplying my pelvis. But now, for my lower limb, we use this external iliac, which becomes femoral. When we call it femoral, when it goes under this inguinal ligament, it enters my thigh region. It gives these lateral and medial circumflex branches, and then you can see that they are surrounding here. Then it gives this arteria profunda femoris, which gives these perforator 1, 2, 3, and then it goes down. My femoral artery, after supplying in my thigh, it goes through a muscle called adductor magnus. You remember Magnum ice cream? So now this goes backwards, and then it's been back of your thigh, at your ankle, at your knee joint, on the posterior aspect, at the popliteal fossa. Now we call it here as popliteal artery. So my femoral artery, where is femoral artery? Femoral artery, after giving its branches in the thigh, in my leg region, we call it popliteal artery. And then we have it anterior tibial, and we have posterior tibial. And then from this posterior tibial, we have common fibular. Guys, peroneal was the old name. And when it comes down at my first web space, dorsalis pedis, guys, one of the very commonly asked item. High yield. When we look at the pulses, distal pulses, like, you recording the radial pulse, this is how we feel for the pulse in the foot. And this is the pulse. We put our finger in the first web space. And when we reach here, we were able to find this dorsalis pedis artery. If I found dorsalis pedis artery, I can say very clearly, my femoral is functional, my popliteal is functional. Femoral I can find in the femoral triangle, but popliteal is difficult to hunt. But if I can find a pulse here, it means my whole track is working. So make no mistake. This is an angiogram. We'll be going in the lab, don't worry for that. And then when it comes to the foot, this is how it makes arches. But these arches are not that way covered like we talk in detail, and we'll be talking in detail about superficial and deep perineal arch, deep arches of the hand. Are we good? So now coming to the lymphatics. But before lymphatics, I like to talk. So ultimately, you can see all the lymph flows to the inguinal region. You can see this T-shaped pattern. Let me remove it so you can see that. Can you see there's a pattern form, this T shape? So this is a classic. These are my inguinal lymph nodes. Then I have the popliteal lymph nodes. But what we need to focus more here, dorsum of my foot, a long vein which goes all the way up. We call him great saphenous vein. And posteriorly, we have small saphenous vein. This is my short saphenous or small saphenous vein. Ultimately, this long and short, they join together, and there are so many perforators, and you can see that they are joining with the femoral vein here. Long saphenous is joining with femoral vein here. This long saphenous vein we quite frequently use for cardiac bypass surgeries. We use as a venous conduit. And even in our body, if we need to replace a vein, and if it is damaged, if it's been traumatized, so we can harvest, we can take this vein from here and we can harvest in those locations. Now you may ask me a question, how we are harvesting? Will it not be affected? No, there is no problem.
So, doctor, just a few of the students can't view the screen right now. So kindly, if you could just like check if the share screen is working.
Yeah, sure.
Thank you so much.
Thank you. We like to do it again. Is it fine, Lean? Okay, good. So people are able to hunt it. So guys, lymphatics, we talk about it. So guys, if we have obstruction, you can see that this is a very famous manifestation where we have some lymphatic flow obstruction. And this is how the patient will present. This is not edema, this is different thing. Okay, coming back, a hiled area. And there we can see the connectivity. What we have done, we have chopped at this ligament. What was this ligament? It was inguinal ligament. And now in a slice, you can see that femoral triangle. This guy is femoral triangle, guys. Let me use another color. So if we talk about femoral triangle, let me make it yellow. So this is my femoral triangle. Can you see a triangular area? And there we can see femoral artery, femoral nerve, femoral vein, and there's a canal. Why we have this canal? Because my vein has to be engorged, has to increase in size. It's been packed by this artery. And can you see someone surrounds all these three structures? What is that? Can you see there is something which surrounds these structures? That is my femoral sheath. And this femoral canal is empty. So my vein can expand only in this direction. And this femoral canal, if it opens up, so a hernia can pop in. And that's called a femoral hernia. I'm sure you learn about inguinal hernia. And this is femoral hernia. Are we good? And there you can see this femoral nerve, which is from my lumbar plexus. And these are remember lateral cutaneous nerve of the thigh, the Calvin Klein thing. If someone is wearing tight things, so this nerve is being trapped and pain and all things is there. We can use that cue for this thing. It's a hiled. Femoral nerve primarily controls the muscles of my front of the thigh. And it supplies, what are these muscles? Quadriceps, quad four muscles, vasta, lateralis, medialis, intermedius, and rectus femoris. You learn about rectus abdominis. Now this guy is rectus femoris. And there is another muscle which goes like this. This is my sartorius muscle. So these are the muscles in the front of the thigh. When we chop these muscles away, now you can see the muscles which are on the medial thigh. And there you can see this adductor magnus, longus, and brevis. And there is this pectineus. Pectineus is there. And you can see here this obturator nerve, it comes down and over this muscle, adductor brevis, it divides into anterior division and posterior division. And this is my iliopsoas. You remember you learn about this iliopsoas in renal when we are talking about psoas abscess. So this is the psoas major, and this is my iliacus. They are joined and they are going to the lesser trochanter of my femur bone. Are we good? This is the adductor hiatus through which when this femoral artery goes, it goes on the back as popliteal. To reach from the front to the back, my femoral become popliteal. How it become popliteal? When it passes through this gap. This gap is popliteal hiatus. Rather, it's adductor hiatus. So from this adductor hiatus, when my femoral artery goes backwards, we call it popliteal artery. Are we guys fine here? Now you're looking at, I'm not showing you lumbar plexus because we have done it with the renal. This is the sacral plexus. And there you can see my main sciatic nerve, one of the biggest nerve. And this nerve is the one which controls back of my thigh, the hamstring group of muscles, my whole leg, my whole foot. All of them, their motor supply primarily, and primarily the sensory supply is all coming from, majority is coming from this sciatic nerve. And this is the main nerve. And if you look at in this image, you can see this sciatic nerve. This is coming, it passes. You remember we have greater and lesser sciatic foramina. In ERP, we spend time. This muscle you're looking at is piriformis. Now this muscle is coming down. It runs in the hamstring compartment, and you can see it gives direct branches here. And there, within my posterior thigh, it divides into tibial and common fibular. You remember in the previous slide, I talked about this common fibular nerve, and then I was showing you if we have fracture in this location, we have a lot of problems. Same thing like wrist drop, we have foot drop, will be connected with that. And then this tibial one, it goes to back of my, or the flexors of my leg, and then it goes to the foot. And this one comes from the lateral side and on the anterior side of my leg and the foot. So these are the three main nerves, the tibial nerve, common fibular nerve, and sciatic nerve. Sciatic nerve is the mother, which bifurcates into tibial and common fibular. Are you fine? And there you can see my pattern of distribution from the both common fibular and the tibial nerves. Now, if we come down, hip joint, a high yield, very strong ball and socket type of joint. And then in this joint, you can see the cavity. And then this guy, can you see this guy? This is the, you remember you learn about glenoid labrum, this is acetabulum labrum. And this is that ligament from which we have that artery, which was the obturator artery. This is the hip bone, we know about it. We have done about it. So you are looking at these ligaments. And again, ball and socket, synovial joint. What are the ligaments? Iliofemoral, pubofemoral, ischiofemoral. I'm sure everybody knows. Iliofemoral from ilium, pubofemoral from pubis, ischiofemoral from ischium. And then stability, shape of the articulating surface. What are the movements? Flexion, extension, abduction, adduction, and medial and lateral rotation. That's it. Now, another important concept in the gluteal region muscle on our butts, gluteus maximus. Once we cut it, we can see the medius and the minimus. There is my piriformis muscle is being shown. And there you can see the sciatic nerve, how it comes down and goes all the way down. We use this piriformis, anything above to it, everything is superior gluteal artery, and below to it, everything is inferior. So when we have to name these nerves, you can see that inferior gluteal. There you can see the superior gluteal artery and nerve. So piriformis acts as a key in this region. Now, fracture of neck of femur, we spend time on that. And then intramuscular injection. Yes, for intramuscular injection, I have a slide upcoming, so I'll not be talking here. Femoral triangle, adductor longus, and sartorius muscle, and my inguinal ligament. This is now known as femoral triangle. It's something like axilla, and we have seen what passes through it. We talk about these muscles already. Guys, this is very important. My gluteus maximus muscle, one of the bulkiest muscle in human body. 3/4 of this muscle forms this band. This is called iliotibial tract, a very strong, which stabilizes my knee when I'm standing. Very strong. And there is another muscle, tensor fasciae latae. It gives very little contribution, but primarily my gluteus maximus, 3/4 of this muscle comes and get into this fascial thing. 1/4 goes to the bone. And this tensor fascial artery come into this muscle. And this iliotibial tract is present at the side of your leg. Knee joint, I'm not talking about it today because I'll be delivering this lecture myself and I'll be covering it also in kinesiology. So simply, it's a synovial bicondylar hinge type of joint. It's not simple hinge, it's a modified hinge. More details, we'll be talking about it. This thing is very important, high yield, anterior cruciate and posterior cruciate, ACL injury. Everybody knows who play basketball, football, or any kind of sports related injury at the knee are mostly knee injuries. And when you're driving, if you hit the dashboard of your knee, you have PCL injuries. They are not that common, but ACL injury, all sports related, you're skiing, you're dancing, you're playing hockey or playing football, ACL is very common. I have a lot of details on this, and that I'll be talking this week. I think it's my lecture number 24th, most likely. Popliteal fossa at the back, same like cubital fossa, no rocket science. On top, we have semimembranosus, tendinosus, and bicep femoris. See, here we have bicep femoris. Don't mix it with bicep brachii. That's why we call it. And down we have this muscle gastrocnemius. Now, the same muscles of the leg, we have anterior group, we have lateral group, and posterior group. Compartment syndrome, we have already talked about it. Guys, compartment syndrome is again a high yield area. Ankle joint, I don't think I can finish in time, so I'm not touching on that, but it's important. Foot, I'll be taking care of that. And there is what I'll be talking most, the arches of the foot. That will be there. And then this we have talked, I'm just showing you. You remember I told you this femoral canal, if it remains open, the loop of intestine can pop out here. This is the femoral hernia, and we learn the inguinal hernia during our GI block. There's no rock. Yes, this is very important. If we have to give an injection, we divide the gluteal region into 4. This is a safe area. If you try to hit here, hit here, hit here, you might damage sciatic nerve, and that has its consequences. Now, this is where we can look for, we can feel for the pulses. This is the, what is this artery? Posterior tibial artery. We have seen dorsalis pedis. This is the location where we can palpate for dorsalis pedis artery, posterior tibial artery. So now, if I look at into your question thing, what are the important ligaments we should know for the shoulder, guys? The glenohumeral, it's superior, middle, and inferior. Primarily about the shoulder, you should be talking about its stabilizing factors. Can you make a session towards the end of MSK for all injuries and clinicals? I think I will, if you stay connected, because I'll be delivering 2 lectures. One is clinical anatomy of upper limb, one is clinical anatomy of lower limb. If you send me your wish list, I can add on those topics and I'll be going over, because my clinical anatomy of upper limb is shortly coming. Tomorrow is I'll be dealing with the wrist joint, and the next lecture is clinical anatomy of the upper limb. So there I'll be able to address those issues. In the go, I have tried to go over with the clinical stuff. If there is anything which still bothers you, feel free to communicate. What are the important ligaments that we should know about elbow? There are only 2 ligaments, so there's no option in that. Random question, but is the vaccine given in the deltoid muscle? Yes, it is given. It's not a random question, it's an important question. It has to be given in the deltoid muscle. Could you please explain the extensors and flexor muscles of the forearm on the cadaver, or do you have a YouTube video? I think I have a YouTube video, and even, you are given an access on the Moodle. If you go in that access, there are videos which has been recorded on our cadavers, and all these muscles have been shown. And if still you are struggling, I think I can refilm. I'm working on something new. I'm refilming the flexor and extensors of the forearm, because a lot of people are struggling with that concept. So stay connected. I'll be working on that. Can you explain the arterial supply of the upper limb? I think I did it. Should we know all the function of the specific muscle? I think you should be knowing the main and major muscles, but there are some tiny muscles you don't know, you can be trusted. But the prime thing is the major, big major ones. There's no excuse. minor one also, like there, there is something, there's a word saying you should know something from everything, not everything from something. If you follow this formula, I don't see you'll be struggling in your exam and you can ace it. Normally what we do, we only do some topics and we leave some topics, and if something comes from those topics which we have not covered, that will be a nightmare and that will be a disaster. So formula is, you should be knowing something from everything, not everything from something. If you learn this, guys, learning is a science and writing for an exam is an art. If you know the art, nobody can stop you from getting an A. I hope I have answered your questions which has been shared with me, which has been added in this Google document. And if still there is anything, I'm available. You know my locations. So then I think we are done. Thank you very much. And it was nice. Long play. I know it's not very short. It was quite a lot, and there was a lot of information. But I'm really happy and I'm glad that I'm able to cover not all, but the major areas of our learning today. So even if you have, even if you have questions, you can write in this Google document and that will be helpful. I'll use it as a guide and then I'll be able to answer during my live session face to face during my lectures with you. Lean, what you're saying?
Sorry, it's me, Doctor, from the Al Faisal Mentorship Program. It's Dr. Maha. I would just like to take the moment to appreciate your cooperation with us and sharing your expertise. Thank you for your time. I know it's a weekend. I would also like to thank the students who still attended till the end. And inshallah, we can work more in the future and collaborate and also avoid the technical issues that happened today.
No problem, Maha. I love it. It was a nice thing. And I love helping people. And I'm always open and available. And this was only a 2 hours session. But, they know me well. And I'm always available for them. So no problem. It's not end of the world. Guys, learning is for everyone. And this is my philosophy. So, and we are here to help you learn. So stay learning. This is what your success and this is what your tomorrow. Feel happy. Wish you all the best for your exams and finals and everything. Enjoy your life.